Well, hello, hello. Today we are going to have a lecture on central nervous system depressants and muscle relaxants. This follows chapter 12 in the 12th edition of Lewis. All right, so let's get going. So what are CNS depressants? All right, so they are any drug that depresses the central nervous system. They're basically classified in two different areas. We have sedatives and hypnotics. So sedatives are those which are used for anxiety conditions, excitability, irritability, and hypnotics actually cause sleep. Some sedatives, and many of them, can actually become hypnotics if given in large enough doses. All right, so let's look at what sleep is. So I'm sure none of you guys know what sleep is anymore now that you're in nursing school. But in general, sleep is considered, per the text, a transient, reversible, periodic state of rest. It's a decrease in our physical activity and consciousness. The normal sleep cycle is cyclic and repetitive. When sleeping, the person's unaware of sensory stimuli and the immediate environment. Our sleep is made up of different types of sleep, including rapid eye movement sleep and non-rapid eye movement sleep. And that's important because a lot of the medications that we give, they can affect our REM sleep. So it's just an important consideration. All right, so let's look at what benzodiazepines are. So they can be either sedative, hypnotic, or anxiolytic. So remember, meds that relieve anxiety. They are commonly prescribed. So I have a kind of a picture here of some of the most commonly prescribed. So alprazolam, clonazepam, diazepam, lorazepam, that halcyon or triazolam, I've never actually seen that here. Temazepam, I've seen that, and Librium or chlordiazepoxide as well. So these are some of the common benzodiazepines. Do you see most of them do end in lambs and pams, so that can help us remember them. So the benzos, again, they used to be the most commonly prescribed sedative hypnotics. Of course, now non-benzos are a little bit more frequently prescribed, and these benzos in general, they have, if they're used appropriately, are generally pretty safe. They work well and not too many side effects, but all things considered, non-benzos are preferred these days. So let's take a look at our hypnotic drugs. So they function like benzos, but they are very different. So these are kind of like miscellaneous ones. So we'll talk a little bit more about some of them, but suvorexant or Belsomra, and then the other one, Tazimelteon. And that is the one that you see on the TV with the folks who are completely blind, where they have that non-24 syndrome. That's the medication that's for them. All right, so benzos. Let's take a look at their mechanism of action. All right, so benzodiazepines suppress our central nervous system. And we do have benzoreceptors. We think that's related to GABA. They don't suppress your rapid eye movement sleep as much, and they do not increase metabolism of the drugs. So this is what made them a bit favorable for us. They end up having a calming effect, and this is why they're used often to combat anxiety and agitation. They can induce sleep. That's not to be confused with being a hypnotic, but just by reducing the stimuli that's hitting the brain, a person can sleep better, and also induces relaxation of the skeletal muscles. So what is it used for? You can see over here. For sedation, to help people sort of fall asleep, anxiety, alcohol withdrawal. Sometimes we use them in conscious sedation. Some contraindications for our medications here for our benzodiazepines are any allergy. Remember, an allergy to the drug is an absolute contraindication to the drug. Those with narrow angle glaucoma and pregnancy. Some of the adverse effects are listed over here for you. They're mild, they're infrequent, but people will complain of headache and drowsiness and kind of like that hangover effect in the daytime. So what happens if there's a benzodiazepine overdose, right? So what you would see in the patient is a somnolence, so excessive sleepiness, right? That is not just, oh, I'm tired. Confusion, they might be fall into a coma, decreased reflexes. It's very hard to pass away from a benzodiazepine overdose because the effects do not really affect our respiratory system or cause hypotension. However, concurrent use of our benzodiazepines with other central nervous system depressants can often lead to respiratory depression and death. So the treatment is generally symptomatic and supportive. However, we do have flumenazole as an antidote for benzodiazepines. Some of the interactions. So any of the azole antifungals, so miconazole, ketoconazole, grapefruit juice interacts with that. Remember our CNS depressants, some of our other medications like olanzapine, some herbal interactions. So we're going to look at some of the drugs themselves. So let's look at diazepam or Valium. When I was younger, I watched a show, I believe it was Spaceballs, the movie, and they had the prince there. His name was Prince Valium, and he kept falling asleep. It was funny. So if you're older, remember Spaceballs, the movie. It's a little nod to them. So this was the first benzodiazepine drug. Use it for different reasons. Generally anxiety, might give it for anticonvulsants therapy, so to stop a seizure. It is available oral, so you can get a pill, you can do rectal forms, or it's also injectable. So that is diazepam. Midazolam or Versed is commonly used in the hospital settings and surgery centers for moderate sedation or conscious sedation. This is the one, it's an amnesiac. It's the one that makes people forget. So if you have somebody who's gone in for like a colonoscopy and they wake up and they say, oh, when am I going for my colonoscopy? It's because of this medication. All right, this is a high alert medication. Midazolam, called Versed. This is the medication that nurse Redonda Vaught thought she was getting when she accidentally grabbed vecuronium. So there are some sound-alike meds, and it is very, very high alert. Another one, temazepam. This is one that is for people with insomnia, so a little bit different, but it is a benzodiazepine. So a person will generally fall asleep in about 20 to 40 minutes. So let that be important when we're trying to figure out when to give these medications. So this is one of those that is a sedative hypnotic. Now this new one we have here, I mean, it's maybe not that new, but it's a non-benzo, but it is isoprolol or Lunesta. That was one of my favorite commercials when it came on. There was this little butterfly that would come into the rooms and the people would be sleeping and they would say, catch the Lunesta butterfly. So I've always thought of that. So it's it's for long-term use. It's a hypnotic. It's designed to give a person 8 full hours of sleep. But because of its long acting, you have to make sure that you can give 8 hours of sleep to it. So probably not great for shift workers, people that have to turn around and get right back up. Another one is zolpidem. So zolpidem is one that makes you kind of sleepwalk, do some things during the night, which you may not remember. So it's short acting, less daytime sleepiness, but they do have a CR form now, which is basically gives you an immediate fall asleep and then a little bit of controlled release to help you stay asleep. So again, this can cause sleepwalking. That's a big safety concern. One of the new ones is very similar to melatonin. And I remember that by looking at the mel and ramelteon to be like melatonin. So it's not a CNS depressant, not technically, but it's used as a hypnotic. It's not a controlled substance, so you can't become dependent on it or withdrawal. So this is for people who have trouble falling asleep rather than staying asleep. And one of the warnings on it is that it can cause hyperprolactinemia, so too much prolactin in the blood. All right, so that was ramelteon. So let's take a look at this guy, the orexin receptor antagonist, so suvorexant, so it kind of tells you it's an orexin antagonist, so Belsomra. There is an abuse potential for this. It's got a long half-life, 12 hours, and so that means that the person might be very, very sleepy during the day. There is a warning on this one about suicidal ideation, and then this also has the nighttime activities that a person might actually participate in that could be dangerous. This is not for narcolepsy. And with Belsomra, those adverse effects are actually more common in ladies. All right, as we go down the rabbit's hole here, let's take a look at our barbiturates. So barbiturates have been out for over 100 years now, and they used to be used all the time. We found out these barbiturates are very habit forming and they have a low therapeutic index. So a therapeutic index is that sort of area and the little sweet spot, if you will, between being therapeutic, meaning it works, and then being toxic, which is it's harmful. So these are narrow or low therapeutic index. So they have to be watched very closely. In fact, there's only a few that are in use today, and all of them we have to watch their blood levels because of the toxicity. So how do they work, right? They work in the brainstem. They potentiate GABA, and that basically inhibits those nerve impulses from the cerebral cortex. The overwhelming result is even though a person might be more sedated, there is a definite reduction in REM sleep, and that causes increased agitation. So they might make somebody sleepy and fall asleep and into even unconsciousness, but when they are awake, they will have the effects of not having that REM sleep. So there's different types of barbiturates. We have our ultra short acting, so that's used in anesthesia and people with seizures if they're actively seizing. Short acting, also used for sedation and seizures. Intermediate action, more sedation and seizures, but then our long acting is just used prophylactically for seizures. So contraindications are over here. Pregnancy, respiratory difficulties, severe kidney or liver disease in our older adults. In fact, our older adults often need half the dose. So that's like an immediate off the top, cut it right there. Let's look at some of the adverse effects. So it can cause vasodilation, hypertension, drowsiness, lethargy, vertigo, respiratory depression, lots of GI. It can cause agranulocytosis and thrombocytopenia. So that means that a person who's on these medications needs to have routine blood work to check their CBC for our white cells and our platelets. Stevens-Johnson syndrome, anaphylaxis or hypersensitivity, all possible. So what happens if somebody has an overdose on barbiturates? Friends, it's not good. Basically, the person can go into a coma and die from that with respiratory arrest. Sometimes this is kind of what we want, right? When we sedate somebody so severely and they're on a, as long as they're on a ventilator, this might be the intended effect of that. But for accidental overdoses and things of that nature, there's really not much we can do in the way of reversal. We basically just have to treat them symptomatically, support that airway with ventilation. They might need IV fluids. They might need pressors to bring their blood pressure up. So really no antidote. Lots of drug interactions. So anytime you have a barbiturate that's taken with another drug that also suppresses the central nervous system, you will have these additive effects. MAOIs, which thankfully are not that common today, can inhibit it. And that means inhibit the metabolism, which means that the drug will be active for longer in the body and therefore potentiate those effects. And then basically, if somebody is on anticoagulants, the barbiturates can inactivate them, right? Leading to clot formation. So let's take a look at a couple of the drugs here we have. We have pentobarbital. So this is a long-acting drug, and this is not used anymore for insomnia, but occasionally pentobarbital is used for status epilepticus, coma induction, and those with a traumatic brain injury. So, and in our certain surgical procedures. Phenobarbital is the prototype. This is the one that is more common, and you can see it's the reduction of, had a glitch, tonic-clonic seizures, febrile convulsions. It can be used to treat high levels of bilirubin in babies, brand new babies, but again, not really used outside of that. There are some over-the-counter hypnotics that we should be aware of. These would be things like doxylamine or Unisom, diphenhydramine, which is Benadryl, right? If we add these anticholinergic drugs, these meds to other meds, they make a person sleepy. So again, just like any other CNS depressant, if you use alcohol or any other drugs that also suppress the central nervous system, you can have these problems with the respiratory depression. So let's go into some of the other meds. Let's look at our muscle relaxants. So muscle relaxants are given to reduce spasms and pain that are related to usually injury, musculoskeletal issues, or otherwise. So most of them act on the central nervous system, and that's why we're talking about them here. And some of them do work on the skeletal muscle themselves, but again, most are centrally acting. So why would we use them, right? So people who have painful spasms. It might be for somebody who has pulled a muscle that is having painful spasms. It might be for those patients who have long-term chronic disorders. Multiple sclerosis and cerebral palsy are two of the most common that would use this class of medications. Now, dantrolene is actually a muscle relaxant, and that is a very, very specific med that is used for malignant hyperthermia. In that case, that would be given in an intensive care unit setting. So that is not what we're talking about when we discuss these ones for chronic conditions. All right, so some side effects are, I gave you 4 here, see if you can figure them out. Sleepiness, weakness, dizziness, and fatigue, right? Because they are acting centrally, which causes a depression. What happens if our patient overdoses? Again, supportive monitoring at this point and supportive interventions. Fluids to avoid crystalluria. We already said caution with other depressants. And right here, I have just a list for you of like some of the most common muscle relaxants. So you'll want to just become familiar with these medications. So if you see them, so baclofen, cyclobenzaprine, there's dantrolene, scalaxin or metaxalone, tizanidine, carisoprodol, chlorzoxazone, and methocarbamol. Some of the most common that you'll see would be this baclofen, methocarbamol, soma. So you'll see them frequently. So let's take a couple of exemplars. Here's one. It's baclofen. Baclofen is available both orally with a pill form. Usual dose is 5 milligrams, but I've given up to 15, 20 milligrams, depending. This is one that can also go in an implantable pump. So baclofen can be in a pump and automatically being released into the system. That is usually the case with our folks with spastic issues of multiple sclerosis and cerebral palsy. Cyclobenzaprine would be the other exemplar medication. So it is oral and extended release, centrally acting. So it can cause pretty good sedation, right? So this is one of those that you wouldn't want to have a person out driving after. You don't want to definitely mix these with anything else as well. All right, so let's talk about nursing implications for these in general, right? Before any therapy, good baseline vitals, checking their orthostatic blood pressures, because folks, if these meds are given to patients, they will have increased risk of falls. Give those hypnotics 30 to 60 minutes before bedtime. Benzos can cause that REM rebound and tired the next day. Teach the patient to avoid alcohol. A person get rebound insomnia a few nights after we discontinue the meds. And then safety is important. How do we keep our patients safe? Our hospitalized patients especially, and also our older adults at home. Monitor for your therapeutic effects, right? They should be working. Now let's see if we can go over a couple little questions here you had in your presentation. So question number 1 says, when providing education to the patient on the use of benzodiazepine, the nurse will include which information? So you can pause it and take a look at those. When you're ready, press play. The answer is that the medication may cause drowsiness the next day. Oops. I already gave the answer for number 2. That was in your thing there, but barbiturates have a low therapeutic index. How does the nurse interpret this? That is the effective safe dose range is narrow. All right, question number 3. All right, number 3, an older adult patient taking multiple medications has a barbiturate added to his medication regimen. When administering a barbiturate to an older adult, what should the nurse expect? And that answer, guys, is to administer half the usual dose. Number 4, which statement regarding muscle relaxants does the nurse identify as being accurate? So you can read all of those. Pause. When you're ready, press play. So baclofen is available as an injectable form to use with an implantable pump device. All right, guys, so that concludes this at this point. So I want to thank you for your time and attention. If you have any questions, please let me know. Thanks.